Our next speaker is Janna Patterson. Dr. Patterson has been a senior program officer at the Bill and Melinda Gates Foundation with the maternal, newborn, and child health team. She manages a portfolio of grants on neonatal health ranging from prevention and treatment of newborn sepsis to the care of preterm infants, including kangaroo mother care. She's a board-certified pediatrician and neonatologist. Prior to joining the foundation, she was a practicing neonatologist and researcher on the faculty of the University of Washington. She's done a lot of work with maternal neonatal infections, HIV, and prematurity. Her education includes a BA in African Development from the University of Wisconsin at Madison. Her MD and her MPH are from the University of Alabama in Birmingham, with graduate medical studies at the University of Washington, Seattle Children's Hospital. Dr. Patterson.
Thank you so much, Dr. Lawrence. It's really a pleasure to be here today. As I was hearing you read my bio, I kept thinking that really the most important reason I feel ready to talk about this today is nothing to do with degrees, but the two children that I breastfed. And that's where you get your real education, right? That 3 a.m. call when you don't have a lactation consultant and you're there by yourself trying to get something to come out of the pump. So the title of my talk is Breastfeeding, the Ultimate Integrator of Maternal, Newborn, and Child Health. And we've spent a lot of time over the last year in the global health community talking about integration and what that means. And in many ways, it's kind of an academic discussion because people who work on the ground will tell you, what do you mean integration? We're doing this all the time. But it's something that I think is worth bearing in mind as I talk today about what does that really mean in the context of breastfeeding. I've learned a little something from each of the people who have presented today, and of course the disadvantage of coming at the end of the day is a lot of the important stuff has already been said. But I'll consider it a success if you at least learn a little something new, or perhaps just think about this, a familiar issue in a new way. So first, I want to talk a little bit about breastfeeding in the context of our global priorities, and then move on to talking about the impact and addressing the problem of suboptimal breastfeeding. And then move more specifically into some of the work of the Gates Foundation, looking at current and future support for breastfeeding. So I think there are a few academics in the audience. In academia, when we design a research study, we usually try to overestimate the size of the sample we'll need to see an effect that's smaller than what we really hope we're going to find, in the hope that when the results come out, we're not in the position of trying to publish a negative study, right? Does that sound familiar to some of you? Right. So at the Gates Foundation, wherein I arrived a year and a half ago, I discovered we do much the opposite, which is set a very audacious goal and then figure out how are we going to get there. And we don't talk much about what's going to happen if we don't reach it, right? So in some ways, it's sort of the antithesis of how we approach things in academics, which is the environment I came from previously. So every year, Bill and Melinda Gates write this annual letter that talks about where are we going down the road, what are we looking at over the next year. And this year, they claimed that the lives of people in poor countries will improve faster in the next 15 years than they have at any other time in history, and that their lives will improve more than anyone else's. So what does this mean for women and children? As I believe you heard this morning, this means that we're reaching for the number of children who die under the age of 5 to be cut in half again, which I would consider a rather audacious goal. The number of women who die in childbirth also to be reduced by 2/3. But our goal of having deaths of children under the age of 5 can't be achieved without addressing malnutrition. Up until now, in many ways, as most of you know, that's kind of been the elephant in the room that nobody has quite called out or addressed directly. But we're starting to get better data, slowly, about why this is so important. We now know that close to half of the deaths of children under the age of 5 are attributable to undernutrition. So not only are many children dying for lack of adequate nutrition, but we also know that many of them aren't reaching their full cognitive potential, their full income earning potential later on in life as a result of undernutrition in childhood. So when we start to unpack undernutrition, causes and consequences, it's a pretty complex picture. We know, as I talked about a couple slides ago, that first line of red boxes, we know what the consequences are. Under 5 and maternal deaths, impaired physical cognitive development, decreased economic productivity, some new data that's emerging and becoming very robust, and compromised adult health and risk of intergenerational perpetuation of this problem. So what does this malnourished child look like? Stunted, wasted, small for gestational age, micronutrient deficient, and suboptimally breastfed, right there at the core of so many of these long-term intergenerational problems. So why is breastfeeding so important? Well, I'm sure each of you could give me an answer to that I haven't even heard yet before. But I think one of the most striking advocacy tools is to really pick out some of those more dramatic data points. And for me, this blue box that came out of the UNICEF A Promise Renewed report just last year, that initiation of breastfeeding within 1 hour of birth reduces neonatal mortality by 44%. That's really quite tremendous. There are very few interventions we have that kind of impact. Yet fewer than half of babies worldwide receive the benefits of immediate breastfeeding. So we know that breastfeeding within the first hour serves as a baby's first immunization. We've talked about, I loved hearing about the golden drops, and that as a tool to emphasize the importance of colostrum. We know that it shapes and primes the microbial environment of the neonatal gut. We know that it reduces the risk of newborn hypothermia through skin-to-skin contact, and that it can also reduce the risk of maternal postpartum hemorrhage. Overall, what does this mean in the big picture? We know that undernutrition, as I said earlier, contributes to 45% of all under 5 deaths. Globally, that means about 800,000 deaths across the world, or approximately 12% of the total are due to suboptimal breastfeeding. But the benefits of breastfeeding aren't just where you don't have clean water, right? Some of the economic studies have estimated that $13 billion annually in the US are associated with premature deaths and healthcare costs due to SIDS, due to neck, otitis media, gastroenteritis, and lower respiratory tract infections. So you don't have to be living out of a puddle in the city of Lagos in Nigeria to feel the benefits of breastfeeding. So when we look at the longer term picture, what does it mean to have suboptimal breastfeeding in terms of DALYs, the disability adjusted life years? We know that poor breastfeeding practices have cost 9 countries, those you see listed here, an estimated more than 1 million disability adjusted life years. And as we talked about earlier, poor breastfeeding practices have a longer term impact on reducing adult income earning capacity. And of course, there are maternal benefits of breastfeeding. I won't spend too much time on this, but just what our grandmothers knew, that breastfeeding can impact birth spacing. We all know it's not a perfect system, but it certainly contributes to the success of family planning across the world. And we know that there is emerging evidence about protection against breast cancer, ovarian cancer, diabetes, and other NCDs, as mentioned earlier today. So what are we aiming for? We're aiming for optimal breastfeeding practices, which we codify as the 1-6-24 formula, if you will. So early initiation of breastfeeding within the first hour, that's our 1. Exclusive breastfeeding for the first 6 months, continued breastfeeding for 24 months or beyond, And that's our gold standard. That's what we're reaching for. But of course, there are barriers, many of which have already been identified. Inadequate counseling and support, right up there at the top of the list. Hopefully we'll continue to propagate peer counselors, as you've highlighted for us this morning. Family and community pressures to introduce other foods, non-human milks or other liquids. Marketing of breast milk substitutes. We've already touched on directly and indirectly how these are marketed to mothers and families. Social norms on breastfeeding. Mother-baby separation. This is an important one. This still happens in hospitals in the United States and is happening everywhere around the world. Sometimes it's a temporary few minutes, few hours during that critical period, and sometimes it's more prolonged. Mothers often lack confidence in their ability to produce sufficient supply. Hot environments. There's often this belief when in warm climates that babies need water and that breast milk is somehow not appropriate or inadequate. And then, of course, hospital or delivery practices and policies that can impair breastfeeding. Not to minimize the impact of health providers' beliefs, as we've discussed before. So what does this look like in terms of data? In studies from Nepal, Ghana, and India, we can see that when you look at all-cause mortality under 5 months of age, that just going to predominant breastfeeding, which is not exclusive but adds a little bit of this, a little bit of that, a little honey, a little water, you increase the risk of death by 48%. Again, pretty big numbers for our public health world. Diarrhea mortality more than doubles. Pneumonia mortality, again, close to doubling, just by adding a little something in addition to breast milk. And then, of course, you can see as you move across the table here from left to right, how the risk increases dramatically when you get over to the column of not breastfeeding. 10 to 15-fold increased risk of death by not breastfeeding. So where are we in terms of our breastfeeding achievements right now? In general, grouping low and middle income countries together, less than half of infants are put to breast in the first hour. 39% below 6 months are breastfeeding exclusively. And you see 40% of all non-exclusively breastfed infants below 6 months of age live in just 3 countries: India, China, and Nigeria. So I just pause for a moment. This is a quote from an article in The Lancet in 1994, over 20 years ago. But if I covered that up, I bet you wouldn't know that it was 20 years old. It says, if a new vaccine became available that could prevent 1 million or more child deaths a year, and that was moreover cheap, safe, administered orally, and required no cold chain, it would become an immediate public health imperative. And I can say that would certainly be true at the Gates Foundation. Breastfeeding can do all of this and more. So while we do have many programs focused on delivery of vaccines, we also focus on breastfeeding. Why? I think that's obvious by now, that support for breastfeeding and complementary feeding can address more than a quarter of the undernutrition burden and benefits both the mother and the newborn. So how do we do this? How are we structured? In the area of global development, which is led by Chris Elias, we have several different program teams. I'm part of the maternal, neonatal, and child health team that you see down towards the second half of the list. And the nutrition team is actually our core team that focuses on breastfeeding promotion. But of course, I was telling somebody earlier today, one of the great things about coming to talks like this and coming to join groups from a broad array of stakeholders is that you get outside of your box a little bit. And the person who really should have been here was our leading breastfeeding guru, Ellen Piwaz, whom many of you I'm sure know. And she is in the field in Ethiopia, and so she came to me and said, would you go talk about breastfeeding? I said, but of course, I'm a pediatrician, I'm a neonatologist. I don't work on breastfeeding necessarily as a specific topic, but for me it underlies the importance of almost everything that I do. So I think one of the ways that we advance this field, and one of the ways in which we achieve new things, is to start talking across silos and to start talking to people who work in a very different place than we do. And so that's part of why I'm here. So in the nutrition team, as you can see, the priority nutrition interventions range from preconception through conception and birth up until 24 months and beyond. And you can see over on the right side of that figure that breastfeeding is a highlight and focus of the work. On the maternal, neonatal, and child health team, where I work, our interventions are arranged really across that same time continuum from preconception to postnatal. And then we also go from facilities at the highest level down to the home and community. And we identify some core high-impact interventions. And I've chosen to highlight the one I think is most relevant for us here today, which is looking at kangaroo mother care. So of course we know that immediate drying of the baby and then putting the baby skin to skin and exclusive breastfeeding is one of the best interventions we can do for preterm, low birth weight. And increasingly, I think we're recognizing the value for all babies. So how do we do this? Through the lens of quality of care. We work to change systems in addition to delivering high-impact specific interventions. So some examples of how we do this is through a safe childbirth checklist in the state of Uttar Pradesh in India, for example, where we've developed a list of 29 items of things that should be addressed by healthcare providers around the time of birth. What's interesting is we implemented this checklist, and it didn't work. And so we came back and started looking at, well, what can we change? What needs to be tweaked? And then when we implemented the nurse mentoring component along with the checklist, that's when behavior started to change, right? So some of this has to be learned in an iterative way, and you learn by doing, and you learn by your mistakes. Also, mentoring and coaching models very similar to what I just described, improvement collaboratives. So we're really trying to bring this process of quality improvement down to a very local level. We're working with the small handful of groups that can go into a facility, hold a workshop, hold a discussion, help people to identify what they want to improve in their own facility, and find a way to change that and track that, and then have check-ins periodically where they can come back and reinforce those messages. Accreditation of mother-baby friendly hospitals. You've heard about this initiative with WHO and UNICEF. That's also a core piece of our work. So integrating programs. I mentioned the importance of venues such as this for talking across silos. And I just want to highlight this again, because kangaroo mother care programs are squarely within the maternal, neonatal, and child health domain. The breastfeeding promotion sits in nutrition, but we all know you don't have KMC without breastfeeding, so really, that doesn't make a whole lot of sense. And I think human milk banking is also something that we've begun to look at and fund across the nutrition and the MNCH teams at the Gates Foundation. And I think putting these together and starting to really understand how they can be mutually reinforcing is a really important leap that we must make. I think people have seen, in some ways, milk banks as a threat to breastfeeding or as an alternative that might decrease, actually, mothers breastfeeding their own child. But I think that's some of the common wisdom, if you will, out there, or lack of wisdom, that I've heard. So I think it's just important for us to continue talking about how these things can support each other, how our messages can be overlapping, and really build this node of lactation support by bringing these programs together. So just again, to come back to some examples of interventions that work, you've heard quite a bit about Alive and Thrive already today, so I don't think I'm going to dwell on that too much, but it was a flagship program that the Gates Foundation funded to really increase exclusive breastfeeding, and has had quite a bit of success, and we're looking now at phase 2 and how we can roll this out in more countries and continue the successes that we've had initially. The 10 steps to successful breastfeeding through the Baby Friendly Hospital Initiative, also important. We know that KMC, as I mentioned, can increase exclusive breastfeeding during that first month of infancy particularly. And Saving Newborn Lives has worked hard on this issue, particularly in Malawi, where they've been able to scale up KMC programs nationwide and really see the benefits from that. And then breastfeeding promotion and support through individual or group counseling. So moving forward, what will the foundation be looking at in terms of support for breastfeeding? We know that we want to continue to reinforce breastfeeding interventions through MNCH services, through the Every Newborn Action Plan working groups, through the Every Mother, Every Newborn initiative, which focuses on quality of care, through KMC, and through human milk banks. We'll continue or increase our commitment to breastfeeding in Bangladesh, Burkina Faso, Ethiopia, India, and Nigeria. And of course, you'll see those last three come up over and over again, because just by sheer numbers, that's where the largest burden of the problem is. We're also going to be focusing more on increasing the evidence base for breastfeeding. There will be a new series coming out in The Lancet in the fall that's likely to come out around the time of the Maternal and Newborn Health Conference in Mexico City, slated for October. And we'll also be investing, as you've heard, I think, from others earlier, in how to really count the economic value of breastfeeding. Part of building the conversation, building the momentum, is advocating with others in the field, other donors, other partners, and we'll be continuing to do that, continuing to update and improve the global breastfeeding databases, and also, lastly, the development of tools to help us measure breastfeeding exclusivity. So there are new tests coming out where you can look at urine, for example, to look at proteins that would help you get an idea of whether or not breastfeeding exclusivity is being maintained or not. And also reference values for various nutrients in breast milk. I just wanted to give a couple of acknowledgments at the end to Isabel Mazzarera, who's a new intern in my office that started last week and was a great help in preparing some of these slides. And of course, Ellen Piwaz, whom I mentioned earlier, our breastfeeding guru. So thank you very much.